Bismillahirrahmanirrahim. I'm Dr. Najib and Dr. Ghulam Mustafa is my moderator today. Today we are talking about metabolic evaluation and pharmacological treatment of urolithiasis. Our objectives today for the today presentation is to know about the stone promoters and inhibitors, 24-hour metabolic study, hypercalciuria, hyperuricasuria, hyperoxaluria, and hypocitraturia. Metabolic evaluation and medical management of kidney stone disease varies widely based on several patients and practitioners related factors. In continuation to the previous presentation, as already discussed about the epidemiology and causing factor of stone, we would continue that there are central promoters and inhibitors for the stone. Regarding promoters, calcium oxalate, urate, cysteine, low urine pH, low urine flow, and bacterial products promotes stones formation. While inhibitors are two types, inorganic versus organic. In inorganic, magnesium citrate and pyrophosphate, while organic, nephrocalcin, Tom Hirschfeld protein. Tom Hirschfeld protein is basically promoter as well as inhibitors. We will discuss it. Protease inhibitors, glycose, aminoglycans, osteopontin, and others. Stone promoters will be discussed in details. So starting from the stone inhibitors, citrate, first of all citrate, it complexes with calcium, so therefore reducing the availability of ionic calcium to interact with oxalate orthophosphate. It directly inhibits the spontaneous precipitation of calcium oxalate and prevents the agglomeration of calcium oxalate crystals and prevents heterogeneous nucleation of calcium oxalate by monosodium urate. Secondly, magnesium phytate and pyrophosphate, mainly they act on calcium stones, reduce contact time of calcium and oxalate, so and inhibit crystal growth. Glycose, aminoglycans, the most prominent one is chondroitin sulfate. However, heparin sulfate interacts more strongly with calcium oxalate monohydrate crystals. It inhibits crystal nucleation and growth by bonding with surface calcium ions. Urinary glycoproteins, nephrocalcin and Tom Hirschfeld protein. These are the potent inhibitors of calcium oxalate monohydrate crystal aggregation. Nephrocalcin synthesized in the proximal renal tubules and the thick ascending limb. It inhibits nucleation and aggregation of calcium oxalate crystals. Tom Hirschfeld protein, other name is uromodulin. It is expressed by the renal epithelial cells in the thick ascending limb and the distal convoluted tubule as a membrane-anchored protein that is released into the urine after cleavage of the anchoring site by the phospholipases or proteases. As I said in previous slide, in alkaline urine, it is a strong inhibitor, whereas in acidic urine, it polymerizes and promotes crystal aggregation. Urinary prothrombin fragment 1, it causes reduction in the crystal aggregation and deposition. While matrix GLA protein is a vitamin-dependent protein that functions primarily as an inhibitor of vascular calcifications. Last one, enter alpha-trypsin, other name is baconin. It strongly inhibits the calcium oxalate crystallizations, aggregation, and its growth. Now, proceeding further, we will first know about single versus recurrent stone farmers. What is a single stone farmer? It is a person who seeks advice for a single solitary kidney stone episode or single kidney stone. While recurrent stone farmer they are having multiple kidney stones, and stones can occur synchronously at or at different times. Patients who form stones at interval greater than 5 years apart fall into a gray zone coined by some others as occasional or episodic stone farmers. For performing the metabolic evaluation, it's American Urological Association recommend that all patients with nephrolithiasis receive a screening evaluation, which includes a medical and dietary history, serum chemistries, a urinalysis, and an intact parathyroid hormone level. A primary hyperparathyroidism is suspected. The full metabolic evaluation for a baseline metabolic profile should be obtained at least 3 to 4 weeks after the last stone passage or treatment. Patient undergoing metabolic evaluation should have an unobstructed urinary tract, and eating their regular diet and without urinary tract infection. So, as we discussed, for single stone formers, we have simplified metabolic evaluation. It would be appropriate for the metabolically inactive patient with a single stone who is at lower risk for recurrence. The first time adult calcium stone former without a family history of stones or any obvious metabolic abnormality may be the patient who can avoid a comprehensive metabolic workup. For a single stone former, we should proceed first. We should take history to identify the underlying predisposing conditions. Medications like calcium, vitamin C, vitamin D, acetazolamide, and steroids, dietary excess, inadequate fluid intake, or excessive fluid loss. Regarding investigations, first multi-channel blood screens, basic metabolic panel is included of serum electrolytes, sodium, potassium, chloride, carbon dioxide, blood urea, nitrogen, and creatinine. Serum calcium level, intact parathyroid hormone, and serum uric acid level. While for urine, first urinalysis, we should do if there is pH is greater than 7.5, it shows infection lithiasis. If pH is less than 5.5, it can give us an idea that uric acid lithiasis. While urine culture, urine splitting organisms like Klebsiella proteus, these are suggestive of infection lithiasis. We can go for imaging. X-ray examination can determine the stone burden and may reveal stone type. Basically, we have two types of stones on X-ray we can differentiate. One is radio opaque stones. These are calcium oxalate, calcium phosphate, magnesium ammonium phosphate, and cystine. Cystine is semi-radio opaque, while radiolucent stones are uric acid, xanthine, and trimetyrene. We can proceed for the stone analysis if we have like a single stone former has passed a stone.
लो और हाई पीएच में कौन से स्टोन बनते हैं?
And the pH is acidic. The oxalate stone and uric acid stone will form. When the pH is high, the ammonium. In low pH, the acidic stone will form in the acidic pH, and when the pH is inclined, the infective magnesium stone will form. Cystine. When pH is more than 7, in towards alkaline nature.
हाई पीएच के causes. हाई यूरिनरी पीएच के causes क्या हैं?
Sir, infections.
और दो और causes बता दें commonly or uncommonly. Stone is interesting as well as boring. These every point is important to remember. So that's why you have to hear about it. When patient is on urinary alkalinizers, the pH will be high. If patient has renal tubular acidosis or hyperparathyroidism, the urinary pH will be high. Which stones will be formed then? Noman, high pH पे कौन से stone बनेंगे? अभी वही बात हो रही थी, आप सुन नहीं रहे.
Calcium phosphate stone.
Calcium phosphate stones. और low pH पे, acidic pH पे.
The uric acid stones mostly form in your low pH, or calcium oxalate also form in pH between the underside.
Continue.
Regarding stone analysis, type of stone and the morphological features of stone can guide us regarding the further proceedings of the stone. Like most stones are a mixture of more than one component. Relative ratios of predominance of any particular molecule has a predictive value. Like calcium apatite and mixed calcium apatite stones are mostly due to secondary to renal tubular acidosis or primary hyperparathyroidism. Pure and mixed uric acid stones can be secondary to gouty diethysis. Bruchite stones are secondary to renal tubular acidosis, and cystine stones are secondary to cystinuria. Pure uric acid, pure infection, and pure cystine stones we can proceed to start treatment. No further testing is required for that. Now coming to comprehensive metabolic evaluation, it's the combination of simplified evaluation in addition to 24-hour urinary collection. Why 24-hour metabolic study? The main goal of metabolic evaluation is to prevent recurrent stone formation in high-risk stone producers, and to prevent the further growth of any existing stones, and to prevent extra-renal complications and associated systemic disorders.
ये हाई रिस्क स्टोन प्रोड्यूसर्स कौन से पेशेंट्स होते हैं? which group of patient? Dr. Kamal.
The patient which form the recurrent stone less than 1 year, the patient who have the family history, and the patient having the stone at the early age. These are considered as a high risk group for the stone.
Tendency to produce concentrated urines. Single kidney has to work for twice. So, and solitary kidney is once again a patient with which needs more attention because of single kidney. They will have more early deterioration of renal functions when they produce a stone.
Patient has to discontinue any medication that interferes with the metabolism of calcium, uric acid, or oxalate, like vitamin D, calcium supplements, antacids, diuretics, acetazolamide, vitamin C, and any current medication for stone treatment like thiazide diuretics, phosphates, allopurinol, or magnesium. Indications for a metabolic comprehensive metabolic stone evaluation. All those patients who have with recurrent stone formation, with history of urinary tract infection with calculi, infirm health, unable to tolerate repeated episodes of uroteric colic, stones composed of cystine, uric acid, and steroids, patients with concurrent medical conditions like nephrocalcinosis, chronic kidney disease, bone disease like Paget disease, and those with a history of bowel disease or bowel surgery. Those having strong history of family history of stones, personal history of gout, solitary kidney with anatomic abnormalities like UPJ, horseshoe kidneys, and children's. These patients should undergo a comprehensive metabolic stone evaluation. While relative indications, those patients whose job requires that they should be without stones, like pilots, frequent business travelers, patients with stone difficult to treat, like urinary tract abnormalities or reconstructions, and immunocompromised person. Third category is patients who are interested, those are having a single stone, but those are who are interested for comprehensive metabolic evaluation. There is discussion about 1 versus 220.
Comprehensive metabolic evaluation का क्या मतलब है? Dr. Arsalan. Comprehensive metabolic evaluation. Is it same as 24-hour urinary metabolic study? Then माइक पे बताएं.
Along 24-hour metabolic study, including serum calcium level as well.
तो इसमें बता रहा था ना कि अगर when you are aware कि stone purely किसी एक ही फॉर्म का है, then you have to be evaluating against that particular. Just like competes में नहीं करते, बच्चों में commonly cystine uric stone होते हैं, cystine stones होते हैं, xanthine stones होते हैं. then you have to target these stones. क्योंकि अगर प्योर स्टोन्स हैं सिस्टीन के, जेंथीन के, यूरिक एसिड के, तो यू हैव टू टारगेट अबाउट प्योर स्टोन है कैल्शियम ऑक्सलेट मोनोहाइड्रेट या डाइहाइड्रेट, यू हैव टू टारगेट अकॉर्डिंगली. बट अगर कॉम्बिनेशन है स्टोन्स की जेंथीन के साथ जो है वो यूरिक एसिड स्टोन्स भी हैं, कैल्शियम ऑक्सलेट स्टोन्स भी हैं, हेटेरोजेनस न्यूक्लिएशन है, स्टोन मल्टीकोर स्टोन्स हैं, then you have to target these two pathologies. So this is not the same as 24-hour urinary metabolic study or complete metabolic evaluation. This is targeted metabolic evaluation towards a specific type of stone. So don't be confused in complete metabolic evaluation and comprehensive metabolic evaluation.
Now, AUA recommend that 2 24-hour urinary studies on a random diet should be collected on 2 non-consecutive days to complete a comprehensive metabolic evaluation for both recurrent stone formers and single stone formers at high risk of recurrence. These are the normal laboratory values for urinary parameters in adults. And this we assess the pH, specific weight, creatinine, calcium, oxalate, uric acid, citrate, magnesium, inorganic phosphate, ammonium, and cysteine.
One of these very important, most important even in metabolic evaluation. Especially in our population, we are living in a stone belt. Who will tell me? No, no. Even Campbell says this is low amount of hydration, specific gravity. We are always ignoring this specific gravity. More the specific gravity, more concentrated urine, more crystal formation. Inhibitors will not be able to stop aggregation, and promoters will not work. Will have more impact on that formation. So specific gravity will tell you that more concentrated is urine, less amount of water intake is there into that patient. Most important is specific gravity, which we always ignore. Patient has to tell about, always we have to tell the patient that you have to increase your hydration level. And specific gravity will tell you that patient has concentrated urine, and concentrated urine is the one when promoters are at peak to work and inhibitors are less effective and stone aggregation, crystal formation starts. Urine will be in the state of supersaturation, formation product will be. Yeah.
Regarding follow-up, AU medical stone guidelines suggest that another 24-hour urine should be repeated after an initial clinical evaluation after 3 to 4 months on selective medical therapy, most likely within the 6 months from the beginning of the treatment, to assess to see what's the response of dietary or medical therapy and to monitor for the adverse effects. After that, follow-up can be yearly. Choosing the best imaging procedure for follow-up must take into account, we should be cautious about the specificity, sensitivity, cost, dose of radiation, availability of the service, risks of contrast, and in some cases need to assess other no stones condition are existing with the same modality. Imaging studies should be typically performed every 1 to 2 years, though the timing and type of imaging can be tailored based on the stone activity, clinical signs, stone location. Aside from kidney stone passage itself, imaging is the most sensitive way to gauge metabolic stone activity. Again, like a short summary, if there is a patient having stone episode, initial evaluation we have done regarding history, physical labs, imaging and stone analysis. There is no recurrence, so we should proceed to we should proceed for empiric dietary guidelines, no follow-up needed. If there is recurrence of stone, interested patient, or there is high risk stone formers, then we should proceed for comprehensive metabolic evaluation to collect 2 samples of 24-hour urine on 2 different times and regular diet. And then we will be directed to the dietary or pharmacological interventions. Now, first coming to hypercalciuria. It's defined as more than 200 milligram calcium and urine for 24 hours. It's the most common metabolic contributor to the kidney stones, and the strictest definition classifies hypercalciuria as greater than 200 milligram of urinary calcium per day after adherence to a 400 mg calcium and 100 mg sodium diet for 1 week. While Parks and Cope defined hypercalciuria as excretion of greater than 4 mg per kg per day or greater than 7 millimole per day in men and 6 millimole per day in women as hypercalciuria. It can be classified into 3 distinct subtypes on the basis of unique pathophysiological abnormalities. First one is absorptive hypercalciuria, which results from the increased intestinal absorption of calcium. And it's defined as urinary calcium excretion more than 0.2 milligram per milligram of creatinine after oral calcium load. The second one is renal hypercalciuria, which results from the primary renal leak of the calcium, and resorptive hypercalciuria resulting from the increased bone demineralization. Regarding absorptive hypercalciuria, there is increased absorption from the intestine, which leads to increased plasma calcium level, increased at step down regulate the PTH parathyroid hormones. Parathyroid hormones decrease the reabsorption of urinary calcium, so there is increased load of calcium in urine, causing hypercalciuria. Regarding renal hypercalciuria, there is increased urinary calcium, which leads there is increased urinary. Primarily, there is increased parathyroid hormones, which increase the bone, act on the bone, the bones, increase bone resorption, and increases GI absorption. That leads to hypercalcemia, which then leads to urinary leak of calcium, hypercalciuria. Regarding resorptive hypercalciuria, there is primary hyperparathyroidism, parathyroid adenoma, like increased level of parathyroid hormone is present. Again, the same bone act on the bone, increases bone resorption, more calcium is released into the serum. There is increased absorption of calcium from the intestines. Plasma calcium level is increased, that leads to urinary calcium. A rough idea about differential diagnosis of 3 types of hypercalciuria. We would first see serum calcium level. It's normal in the first 2, like absorptive renal and resorptive hypercalciuria. There is elevated serum calcium. And absorptive parathyroid function is suppressed, and renal it's secondarily stimulated, and resorptive there is primary hyperparathyroidism already in an increased level. Fasting urinary calcium can differentiate between the absorptive and other 2 types. It's normal in the absorptive, while elevated in the renal and resorptive states. Again, few words about regarding resorptive hypercalciuria. It's caused by the overproduction of PTH from either one dominant adenoma or diffuse hyperplasia of all 4 glands. Should be suspected in a patient with hypercalcemia, high percentage of calcium phosphate and composition, and high urinary calcium level. There are certain medications like thiazide diuretics, lithium, that can cause increase in PTH level. So one should care before measurement of PTH, and even dietary calcium causes transient elevations and serum calcium levels. Therefore, a fasting serum calcium level is preferred. Now coming to intervention or pharmacological treatment. First, general preventive measures. General preventive measures are almost same for all kind of stones. So first, as sir already mentioned regarding specific gravity, that our population has decreased consumption of water. They are almost dehydrated most of the time. So fluid intake, we should advise fluid amount from 2.5 to 3 liter per day, so that there may be a diuresis of 2 into 2.5 liter per day. And regarding fluid intake, a patient asks us how much amount of water should I take per day? And we usually can say that you should take this much of water that color of your urine is white. Circadian drinking, like we should advise the patients to take water round the clock. Not if a patient is consuming water at specific hours, but then he remains without fluids. So we should advise the patient regarding that. Regarding nutritional advice for a balanced diet and diet rich in vegetable and fibers, normal calcium content should be limited from 1 to 1.2 gram per day. Limited sodium chloride content like 4 to 5 gram per day. Limited animal protein content 0.8 to 1 gram per kg per day. And regarding lifestyle advice to normalize general risk factors like BMI, retain a normal BMI level, adequate physical activity, balancing of excessive fluid loss.
सोडियम डाइट में कम क्यों करते हैं? कोई सोडियम के स्टोन बनते हैं क्या? डॉक्टर हसन, सोडियम रिस्ट्रिक्शन क्यों?
So because of the sodium calcium channels, if the sodium will be reduced, there will be the absorption of calcium will be otherwise increased, so that can cause oxalate stone. Calcium.
क्या करता है सोडियम? एक्सेस में सोडियम कंज्यूम किया तो क्या होगा?
So it will.
We are restricting sodium, na?
It would
for-
decrease the sodium calcium reabsorption.
Anyone else? डॉक्टर अब्दुल राजिक, अभी डिस्कस हो चुका है अभी रिसेंटली.
Sodium and calcium, they have a common transport mechanism. So if
Great.
you restrict the sodium, then you're restricting the calcium at the same time.
So it increases the calcium excretion of urine. यूरिन में कैल्शियम की जो कंसंट्रेशन को बढ़ाता है सोडियम क्लोराइड. ठीक है हसन, got it?
Like sodium and calcium share a common transport mechanism in renal tubule. High sodium intake causes decreased proximal sodium reabsorption, which leads to reduced distal renal tubular calcium reabsorption and causing hypernatriuria and hypercalciuria, which are the risk factors that contribute to calcium nephrolithiasis. 100 milliequivalent increase in dietary sodium. There was seen a 25 to 40 mg increase in urinary calcium excretion in normal subjects and 80 to 120 mg increase in hypercalciuric stone formers. Animal protein restriction and moderate calcium ingestion, a reduced sodium diet decreased stone episodes by roughly 50%. Now, regarding medical therapy for hypercalciuria, first line is thiazides and thiazide-like diuretics. Prepar agent, these are the prepar agents for hypercalciuria. Regarding mode of action, this is a sodium chloride channel. Thiazide diuretics inhibits these channel. Consequently, there is a decreased sodium in the distal convoluted tubule cells. So sodium comes from blood to the cells, and at this channel, calcium is reabsorbed here. This channel is activated. It's also augmented by parathyroid hormone. So calcium influx increases, causing hypercalciuria. So thiazide diuretics basically inhibit this channel. Now coming to hypocitraturia. Hypocitraturia is defined as urinary citrate level less than 550 milligram per day in female, while less than 450 milligram per day in males. It's the second most common cause, and acid-base test is the primary determinant of urinary citrate excretion. Citrate mechanism of action of citrate firstly it reduces urinary saturation of calcium salts by complexing with calcium, directly prevents spontaneous nucleation of calcium oxalate. It inhibits agglomeration and sedimentation of calcium oxalate crystals, as well as the growth of calcium oxalate and calcium phosphate. Finally, normal urinary citrate levels can enhance the inhibitory effect of TOM horse-fall glycoproteins. The causes of hypocitraturia are first systemic diseases like distal renal tubular acidosis or chronic diarrhea, like medication like thiazides, urinary tract infections, and idiopathic process. Conservative management of hypercalciurias. Natural juices are the highest in citrate and potassium content, with grapefruit juice containing the greatest amount of 197.5 milliequivalent per liter, followed by closely by lemon and the orange juices. High fluid intake, more than 3 liters to produce more than 2.5 liter urine per day is required. Several studies compared the reconstituted lemonade, one who's up lemon in the cup of water, to 60 milliequivalent of potassium citrate, and found that potassium citrate increased urinary citrate, but the lemonade solution did not. Regarding medical therapy, it's typically accomplished with citrate repletion.
Dr. Zoha, which drink is better for stone prevention?
So lemonade.
What we were discussing now. We were discussing lemonade is not. Why? You see, lemonade has, this content that lemonade has less amount of potassium, good amount of citrate, but less amount of potassium. And this is why it has not that much good effect on stone prevention. When any fluid contains sodium, potassium and citrate both, then it will have good effect on stone prevention. This was discussed in it. So potassium and citrate both are richly present in grapefruits and orange. And they were found to have more effect on stone prevention than lemonade alone. This was discussion.
Oral ingested citrate salts are metabolized to bicarbonate and the liver, and resulting alkali load in turn inhibits proximal tubular citrate reabsorption, which leads increased levels of citrate in the urine. We mostly use potassium citrate. It's the predominant form. Its dose is half milliequivalent per kg per day. It's given in the divided dose. Some others say that it can be given as an evening dose until the urinary sufficient alkaline pH is achieved from 6 to 6.5. Can anyone tell please that what's the strength of Urocit K, which we normally advise in OPD? It's almost 10 milliequivalent per tablet. So if there we have an adult patient like up 70 kg, so at least he needs 30 to 35 milliequivalent per day. So mostly we prescribe it in BD, 2 tablets. So I think it's insufficient dose for that. Sodium citrate is another formulation that is reserved for the patients with the concerns about causing hyperkalemia. And common side effects of potassium citrate is GI upset and hyperkalemia. So potassium levels should be regularly monitored for patients with renal insufficiency, and that should be avoided for those patients who are on potassium sparing diuretics like spironolactone. Exceedingly alkaline urine also raises the risk of calcium phosphate stones formation, particularly at a pH of 7 or greater. High utilization of citrate therapy has been postulated to contribute to a serious rise of calcium phosphate disease because that of the pH factor. Now coming to renal tubular acidosis, type 1 distal renal tubular acidosis, mainly or urological concern. The hallmark of this disease is a low urine citrate with hypocitraturia with inappropriately high urine pH. On 24-hour urinary metabolic study, we will see hypercalciuria, hypocitraturia, high urine pH 6.5 or above, and hypokalemia with hyperchloremia. Up to 70% of adults with distal renal tubular acidosis have kidney stones. Patients with an onset of at early age with severe forms of disorder may develop nephrocalcinosis, which eventually leads to renal insufficiency. Causes of acquired renal tubular acidosis are obstructive uropathy, recurrent pyelonephritis, acute tubular necrosis, renal transplantation, analgesic nephropathy, sarcoidosis, idiopathic hypercalciuria, and primary hyperparathyroidism. Alkali supplementations of potassium citrate in the form of a cornerstone therapy for renal tubular acidosis, as it is able to correct the metabolic acidosis and hypokalemia found in the disease. Also, potassium citrate must be added to patients receiving thiazides diuretics, as we discussed previously that it causes hypocitraturia. So to counter it, we should add potassium citrate. Now coming to hyperoxaluria, it's more than 40 milligram per day.
Dr. Kamal, only distal renal tubular acidosis causes stone formation. Why not other renal tubular acidosis cause this?
Because of the absorption solute in tubular acidosis, and in the proximal tubular acidosis, not considered with the stone formation of this exactly sometime, but sometimes it also causes the proximal tubular acidosis also causes a stone of somehow.
Almost not. Proximal renal tubular acidosis can be corrected distally in renal tubules. That's why urine pH and promoters and inhibitors can be managed distally into the nephron and tubules. But if renal tubular acidosis pathology is in distal, then there will be no way, no passage of urine where ions and pH can be maintained or managed. That's why only distal renal tubular acidosis cause high urinary pH and calcium phosphate stones forms in these cases, or calcium hepatite. Okay. Other tubular renal tubular acidosis don't have significant impact on pH. That's why.
Regarding hyperoxaluria, it's more than 40 milligram per day urine, and it is one of the more common metabolic abnormalities. There is no set level above which stone rest suddenly occurs. Like at normal level of oxalate in the urine, here can be a calcium oxalate stone formation. It's stated that deficiency of a bacterium found in the intestinal flora with the name of Oxalobacter formigenes is a factor in the formation of calcium oxalate calculi. There are three types, enteric. First one is enteric hyperoxaluria, which is used to describe elevations in the urinary oxalate levels more than 40 milligram per day, which is resulted from the GI malabsorption and chronic diarrhea. Regarding malabsorption, it may be disease of the gut, or recently we are seeing bariatric surgeries, which mainly leads to increased oxalate reabsorption as a result of saponification of oral calcium with the poorly absorbed fats in the GI tract. All that can also increase stone formation via dehydration, hypokalemia, bicarbonate loss, and hypocitraturia. Urine oxalate levels can be 60 to 70 milligram per day and enteric hyperoxaluria. Regarding primary hyperoxaluria is caused by end-burn error of biosynthetic pathway. There are three genetic types of primary hyperoxaluria. Type 1 is the most common variant, which is caused by defect of enzyme alanine glyoxylate aminotransferase. Type 2 is caused by deglycerate dehydrogenase, and type 3, which can occur as a result of mutation in hydroxy to oxoglutarate aldolase gene, and it is inherited autosomal recessive manner. Estimates suggest that 70% of patients with primary hyperoxaluria have type 1, 10% have type 2, and 10% have type 3. The main defect is normally glyoxylate is degraded into glycolate or glycine. But due to this defect and this is primary hyperoxaluria type 2, It's a channeled glycolate as a channeled instead up to these two places. It's degraded into oxalate. Disease usually manifests during early childhood with early stone formation, and there is deposition of oxalate, a term called acidosis, deposition of oxalate in various parts of the body. And it eventually causes nephrocalcinosis. Death can occur before 20 years of age in untreated, unnoticed patients. Metabolic evaluation will reveal high urine oxalate excretion, often more than 100 milligram per day, and high serum levels of this molecule. Its management is mostly conservative. Cornerstone treatment of hypercalciuria is food restriction. Foods containing high level of oxalates like black tea, cocoa, spinach, mustard greens, Swiss chard, beets, and rhubarb. These should be strictly restricted to patients. Regarding medical therapy for hyperoxaluria, idiopathic and primary hyperoxaluria, these can be treated with low oxalate diet and pyridoxine, vitamin B6, which we discussed in previous. It's a vitamin B6 cofactor for this enzyme. While enteric hyperoxaluria can be treated with calcium supplementation of 1 gram per day and divided dose with high fluid diet at minimum over 2 liters per day. Hyperuricasuria, it's more than 800 milligram of uric acid and urine per day. There are mainly three causes of uric acid nephrolithiasis. First one is low urine pH, low urine volume, and hyperuricasuria. So first we discussed hyperuricasuria. Hyperuricasuria may be caused by uricosuric drugs like probenecid, high dose salicylates, radio contrast agents, or losartan. While urate overproduction due to gout, high dietary purine intake, myeloproliferative disorders, hemolytic anemia, chemotherapy-induced tumor lysis. Urate 1 mutations, hyperuricemic, and hyperuricasuria. Regarding low urine pH, uric acid metabolism in urine is mainly pH dependent. At pH less than 0.5, 5.5, a little amount of uric acid can remain insoluble, can't be degraded. While a pH more than 5.5, a high level load of uric acid can be degraded. Regarding low urine pH, there is decreased urinary ammonium excretion, increased endogenous acid production, increased acid intake, increased base loss. Regarding low urine volume, there may be chronic dehydration, excessive respiration, excessive exercise, and chronic diarrhea. Now, coming to the treatment of uric acid nephrolithiasis, we come to the basic evaluation of uric acid. pH is less than 6. So we have to rise the pH. We used alkaline citrate 9 to 12 gram per day or sodium bicarbonate. Second one is hyperuricasuria. If it's more than 4 millimole per day, then allopurinol is advised in 100 milligram per day. If it's more than 4 millimole per day and here is hyperuricemia greater than 380 micromole, then we have to advise allopurinol in a dose of 100 to 300 milligram per day. Regarding ammonium urate stones, basic evaluation, urine pH is greater than 6.5, then we will see either it be due to UTI, so antibiotics are prescribed for it, or it be due to we can advise methionine 200 to 500 milligram in TDS. So our target urine pH is 5.8.
टारगेट पीएच का कैसे पता चलेगा कि ये टारगेट पीएच जो है वो यूरिन की अचीव हो गई है? एनीवन केम फ्रॉम पीट्स? माइक ले ले.
We advise the patient to check the pH at home daily. Usually in the market we have the litmus paper. And
Litmus paper, very
Yeah.
right. So he or she has to check pH with litmus paper, and we have to teach them how to check it.
So a brief summary, there is stone episode, and there is recurrence. We have taken the history and the general metabolic evaluation. Then we comes to the serum studies. If there is uncomplicated calcium stones, normocalcemia, no bowel disease, no UTI, normocalciuria, hypercalciuria. Hypercalciuria is treated by thiazide diuretics with potassium citrate, or with potassium citrate if urine citrate value is normal, or if there is urine citrate level low, so we should advise potassium citrate along with it. If there is normocalciuria, we give potassium citrate. Other stones, hypercalcemia, hyperparathyroid investigation and to treat underlying cause. If there is uric acid stones, if we use potassium citrate, if relapse, or we already discussed that we can advise allopurinol. Regarding hyperuricemia, gout, allopurinol is drug of choice. Cystinuria, fluids as main cornerstone treatment. If infection stones, antibiotics are given. Thank you.